So, hello everybody. Welcome to the sixth webinar organized by the Tunisian Society of Cardiology and Cardiovascular Surgery in collaboration with the Minarini Laboratory and dealing with COVID-19 cardiovascular disease tips and tricks for your toolbox. In fact, our target as a scientific society is to bring information to cardiologists, doctors, and benefit from the experience of other experts in the field of COVID-19. This afternoon, after Wuhan, we choose to go to Europe and to USA, where the coronavirus pandemic is still spreading with thousands of deaths. This afternoon, in this International Cardiovascular Summit, we are very pleased and very honored to have with us the president of two prestigious cardiology society. We have Professor Barbara Casadei, the president of the European Society of Cardiology, and Professor Richard Kovacs, the president of the American College of Cardiology, Professor Mike Valentin, the past president of the American College of Cardiology. Welcome with us in Tunisia, and they will share with us their large experience in COVID-19 field. Professor Casadei will talk about COVID-19 and acute coronary syndrome, the collateral damage of coronavirus pandemic. Professor Kovacs will talk about the response of major medical centers to the COVID crisis in America. And in the second time, we will talk about gaps between the observational and the randomized trials. And Professor Mike Valentin will talk about the role of open communication and web-based service in improving the care in COVID-19 crisis. This webinar is moderated by Professor Faiez Zanned, our Franco-Tunisian cardiologist. He is the honor member of the Tunisian Society of Cardiology, and he is also Professor Emeritus of the Therapeutics and at the University of Lorraine, and past president of the French Society of Hypertension, and also by my friend, Professor Afef Ben Halima, member of the board of the Tunisian Society of Cardiology and Cardiovascular Surgery. Before handing over the moderators, I would like to present a brief flash of the epidemic situation in Tunisia. So I will share my few slides. Tunisia has her first case on the 2nd of March, and until yesterday we have 1,035 coronavirus cases with 45 deaths. The rate of mortality in Tunisia is about 4%. This rate is low compared to the rates of Maghreb countries such as Algeria, especially Algeria with 8%. And these curves show that the numbers of new cases in Tunisia are decreasing. So if you see here in these curves, on the 4th of May, target containment strategy began in Tunisia. And on the 10th of May, we have zero new coronavirus cases in Tunisia for 5 days. Unfortunately, yesterday we recorded 3 new cases in Tunisia. So what are the explanation of this miraculous situation in Tunisia? We have a few numbers, low mortality, and very few new cases. The government has chosen to take proactive measures and exceptional measures. Early, the Tunisian government imposed a curfew and a general lockdown since 22 of March, when we have only 75 cases. And the Minister of Education declared on 29 April that the schools are over for all levels except for bachelors. Tunisia also suspended all international flights and closed its land in an effort to prevent the outbreak of the coronavirus. All gatherings and markets have been banned, and work our state employees have been reduced. Travel is banned except for repatriation and quarantining of Tunisian nationals. and schools and mosques were closed. So it was just a flash of the epidemic situation in Tunisia. And up to you, Professor Faiez Zanned, to moderate this webinar and to invite the speakers.
Thank you so much, Leila. It has been a pleasure listening to you and listening that the situation in Tunisia is almost under control. And what you've shown, and because we are privileged here today to have our eminent specialists from Europe and from the United States, is that this pandemic didn't really hurt countries in the similar ways. And this is an important question. We don't know why. So hopefully we'll understand better why the different countries and different continents have been hit differently, whether it is only related to different health policy or some sort of epidemiology trick. But then the main issue everybody has to face in these epidemics is how to handle patients and how to treat them, because this is a new disease. And in cardiology, more than any other discipline, we are so much spoiled by evidence-based medicine. Now, there is no evidence in this coronavirus disease, and anything we can learn from our colleagues who have been fighting this disease is very useful, because it's going to be experience-based medicine. So sharing experience is extremely important. Now, of course, you can get experience from reading the literature and reading social media. Unfortunately, there have been so many fake news and disinformation and bad information, even in major journals, by the way. So this is what the WHO has called the infodemics, because it's the epidemics of information. So I thought that your initiative was really great in order to have people who are hands-on and who has captured the best of the literature from Europe, United States, and to share this with our colleagues in Tunisia. So this is a great experience, and webinar in this space is certainly very useful, and you must be congratulated in putting together this webinar. So without further ado, I am really pleased to introduce, I believe this is ladies first, so maybe Barbara, to get and experience, let us know how in Europe this disease was handled, and certainly among the European cardiologists first. Barbara, please.
Can you hear me now?
Yes, great.
So,
full screen, please.
I thought it was. So, thank you very much for having me. In the UK, as you know, we've had since the 6th of March, 50,000 deaths due to COVID-19. And it has been a very harrowing experience for all of us. I think deaths from this disease is really in everybody's mind. And you can see here how, to some extent, Africa has been spared, whereas Europe and North America have been hit really badly. You know, that can be due to a lot of reasons, including the age of the population. Because one has to take into consideration that the vast majority of these deaths are really in the elderly. And so they reflect, to some extent, the proportion of elderly people in these populations. About 3/4 or over 3/4 are in the elderly worldwide. So as you can see here, as I said, Africa has so far, possibly for that reason, done particularly well, and Tunisia has done fabulously well, as you can see here. If you compare again the number of deaths to those recorded and still going in the US, in the UK, Italy, and France. So even with a toll of about 300,000 deaths worldwide for COVID, this is actually has to be put in proportion, in perspective to what are the deaths for cardiovascular disease. So 17.7 million people die every year from cardiovascular disease, and about 7 million of those do so prematurely, and that is before the age of 69, and that is the definition. So why am I saying this? You may say, well, this is not a competition, right? The COVID 300,000 deaths are not trivial. And certainly there is a strong psychological effect of something that one can catch very easily as a very infectious virus. And then one doesn't quite know how hard the illness that follows is going to be. So these are very disturbing facts. Nevertheless, I think, as I said, they need to be put in perspective with cardiovascular disease. And I'm saying this because over the time of the COVID-19 pandemics, cardiovascular disease has been largely neglected. So this has happened because, has started to become apparent from the lay press that published a number of articles such as this one in the New York Times saying, where are the patients with acute coronary syndromes? Where are the patients with heart failure? All of a sudden, there was no one coming to their hospitals with acute coronary syndromes. And this is really counterintuitive because we know that in the presence of a pandemic of an infectious disease, we would expect to see an increase in coronary syndrome, mostly because of maybe inflammation, but certainly during the peak of the influenza epidemic, the risk of having a heart attack during the first week of influenza is usually up to 6 times greater than normal. So we have an infectious disease that causes inflammation that is supposed to increase the number of acute coronary syndrome. And at the same time, we can't see, that there are this report of a reduction. And of course, this is perception. And as perception goes, you think, oh, maybe it's just some kind of cognitive disconnect between what really happens and what one is expecting. But in the UK, we have a centralized system and we can actually count quite rapidly the cases and what happens. And very rapidly, it became apparent that this reduction was actually real. You can see it here. It's a very dramatic, perpendicular reduction starting before the lockdown, just after the first death for COVID was reported in the UK. So faced with this, this is admission for any cardiac patients. So following this data, we became very interested in the European Society of Cardiology to see which patients were not coming to hospital, because we know that it is different if you're coming to hospital because you maybe have a little bit of palpitation or whether you have a STEMI. Because we can do a lot for patients with STEMI. It's one of the area of medicines with the greatest evidence-based management. We know we can save lives, and we know we can do that very rapidly. So we became interested in this, and so in having a survey across 5 continents, really, to look at STEMI admission during COVID-19. And again, we match this with actual data collection, where this is perceptions. And you are the first people, I must say, to actually see these data, because they are really just being analyzed. And we did that really under the, if you like, the slogan that we need to continue to save the lives that we know how to save. And so, okay, we have a pandemic, okay, this is putting our health systems under a significant amount of stress. Nevertheless, we can only support people with COVID-19, but we can actually evidence-based treat the patients with STEMI. So we ran this survey. As I said, we had 3,000 responders, mostly were from Europe, but also from Asia, South America, Africa, North American. And here I would like to thank our colleagues from the ACC who helped us collecting some data from North America. Mostly we asked, is your country in lockdown? Has there been restructuring? So are the shops closed? Are the schools closed? And you can see here the vast majority responded. These are the total data here, and then per continent. You can see that they are similar, with the largest amount of proportion of lockdown in Europe and the lowest in Africa. So then we asked, to have a sense really of how much hit that particular hospital or was by COVID-19 admissions. How many COVID patients are actually admitted to your hospital. And you can see here that the largest numbers, about 50 to more than 200 is recorded in Europe, and the lowest in Africa, in accordance to what actually we know. Then we asked, has your ward, your unit or department been restructured as a result of the COVID pandemic? And it's, in the expectation that a surge of patients would come to your hospital, and therefore you would have to maybe close some wards and transform others in intensive care beds for these patients. And you can see here that the vast majority said that that is indeed what happened. About 50 to 60% said that there was a restructuring, either partial or total. So then we go to the most relevant questions that are, have you perceived a change in the number of people coming to hospital with a STEMI since the outbreak? And you can see here that indeed the vast majority said yes, the amount has decreased, about 80% overall. And you can see that there have been 2 to 3% that said that the amount had increased, and attributed that increase to health anxiety at the time of COVID, and possibly also to a true increase in the number of STEMI patients. But, they were a tiny minority, and also a minority of between 10 and 20% said that the amount didn't change. So when we then ask, okay, it has decreased, by how much do you think it has decreased? And 65% of those who reported a reduction in STEMI admission indicated that it was greater than 40%. And this is, in fact, what we have measured in actual data in the UK, in Spain, and in Austria. So then the other question that came out a lot anecdotally has been that, okay, not only we see less patients, but the patients that we actually see coming in with STEMI are coming too late to benefit from primary PCI or even thrombolysis. That is unusual. I mean, we don't expect someone with a STEMI syndrome, how severe that is, to actually nurse it at home. Although there is all evidence that this is exactly what has been happening. So we asked the question, do STEMI patients present later than usual and beyond the optimal window for PCI and thrombolysis? And again, 60% or so said yes. And when we say, well, really, what kind of proportion of patients come late? And they said more than 50% of those who are admitted, who actually make it to the hospital, arrive too late to have treatment deployed at the time where we know very well this treatment is effective. So if you consider the mortality and the severity of STEMI, the impact of this reduction is enormous. And the same data are now being collected for cancer, for other diseases, for stroke is exactly the same. And so you think that the actual damage that the pandemic has had as a sort of collateral damage is certainly very significant. So to summarize this data, it is in agreement really with the perceptions are very much similar across the continent, and they are very much in agreement with the data that we collected. So the majority of the health professionals we surveyed, cardiologists and 10% of nurses, reported a reduction in STEMI presentation of at least 40%, as well as significant delays in the presentation of those who make it to hospital. So, as I said, this indicates that the collateral damage is potentially huge. And why am I showing this data? I'm showing this data because I'm not so optimistic that we have seen the end of COVID. And I think that as the lockdown measures are starting to relax, we may well see another wave. And if we see another wave, we have to be absolutely certain that we don't make this mistake again. And I would say that both National Cardiac Society and international cardiac societies, such as the European Society of Cardiology, the ESSC, and others, really have the responsibility to develop strategies that really, so that the patients are informed of the relative risks of coming to hospital or stay home with chest pain, how important it would be to actually go and seek appropriate care. But also we need to lobby the hospital, the governments, that we need to continue to deliver services for non-communicable diseases, and also provide, assure that there are areas as safe and clean as possible to house these patients, because the fear of infection is really one of the main reasons why people don't come to hospital, even with this very severe syndrome. So with that, I would like to thank the people who have looked at the ESC COVID-19 pages, which we have really tried to make as practical as possible. As you can see, we had the questionable distinction of having been hit by COVID before our US colleagues. And so our US colleagues have been amongst those who have really looked at the little practical videos and documents that we put in our webpage that has had 280,000 hits until now. And I would like you to remind you that we will have a digital ESC Congress at the same time as it would have been in normal, in pre-COVID era, and I do hope that you will all contribute and participate to this event. Thank you.
Thank you so much, Barbara, for this real, very challenging data, and thank you for the European Society of Cardiology for having collected them. Now, I'm sure there will be questions, but I get started with one question, which is, I'm struggling about the long-term effects of what is presented here today, because if the hypothesis is that patients have been hiding away from getting to emergencies or getting to the hospital, then we will see in a very short time the increase on mortality rate, right? Mm-hmm. I can remember, actually, this can go very fast. I can remember in France when we stopped smoking, when banned smoking in public areas. Yeah. And it was the case in Europe as well. In weeks or months, mortality from myocardial infarction declined very significantly. So we are bound to see this result on mortality very soon. Are you following this, and are you collecting data from the places where you have run this study in order to find out whether this is the case?
Yeah, I mean, the collection of all-cause mortality or even cardiovascular mortality data now is challenging. It's bound to be confounded by the COVID mortality and everything else. So it's not going to be that easy. I mean, in fact, the WHO is trying to collect this kind of mortality, but there are really difficulties in attributing causes of mortality at this particular time. What I think, though, we can see very clearly is that, and unfortunately I am old enough to say that, and that we're starting to see what I used to see as a medical student, and that is patient coming with enormous aneurysm of the ventricle, with that kind of pictures that we are no longer used to see, with mechanical complications of a myocardial infarction, with really something that I haven't seen for at least 30 years. And so I think that kind of collection of this type of data would give, if you like, a more precise picture of this damage. Heart failure, the occurrence of heart failure, the complication.
Yeah, you mentioned two words in your answer. One is that diagnosis can be confounded, and then you said that, well, we may have a more precise picture. Well, I'm not sure how precise, because the confusion may be really high, because many of the patients at risk of getting COVID are cardiovascular, obese, hypertension, and elderly. Those are the main risk factors of myocardial infarction and STEMI. And I understand that in COVID, troponin is also high. So it may be simply that either for competing risk, people are dying from COVID while actually having an MI, or the other way around, it's just misdiagnosed MI has been misdiagnosed as a COVID. So detangling this is going to be extremely complex. What is your take on this, on the diagnostic issue?
No, I'm sorry I didn't make myself clear. I think the attribution of the cause of death is going to be problematic. But actually to see that the consequences of an untreated STEMI is going, there is where you have a bit more precision. The fact is that, yes, undoubtedly, there is a interaction between COVID and coronary and cardiovascular coronary artery disease. So it is possible, like it has been shown for influenza, as I said before, that during the infection, the fact that COVID affects patients with cardiovascular disease more than others is nothing new. In terms the influenza does exactly the same. Any major viral illness seems to cause the greatest damage in patients with diagnosis of coronary artery disease or diabetes. And so this is what we have seen before, but not at this scale. So there will be, without a doubt, a higher number of patients dying, with the combination. But we also know that these patients are not coming to hospital. And that, I think, so even what we can do, we cannot do. If patients don't come to hospital and do not come to hospital in time, then really the damage can be enormous.
Excellent. So I'm here referring to our organizers, whether you would like to invite questions or we move on with the next speaker and we'll have questions later. Leila, shall we move on? You are on mute, Leila.
We move on to the next speaker and we keep the discussion at the end.
Good, excellent. So I'm most privileged to introduce Richard Kovacs from the American College of Cardiology, current president, and we'll hear the experience from the other side of the Atlantic. Good morning, Richard, and thank you very much for being with us today.
Thank you very much for having me, and my partner in crime, Dr. Valentin, will participate as well. So thank you, and my slides are up, and I also want to check. Can you see my pointer on the slides? I have two screens, so have to make sure I'm sharing the correct one. So thank you for having me and Dr. Valentin to address this. I think that this is going to be a complementary to Professor Casadei's discussion, and I think she really framed this up very nicely. So let me show you a little bit about the very, very recent things that are going on in the United States. And I was asked to describe how we're leading this from our academic health centers and the responsibility that these centers have for really driving the clinical decisions, but also the public policy. So I have nothing to disclose regarding this, but I'm going to really divide this into three parts and touch on this issue a little bit about the cardiac manifestations of the COVID itself. And we've touched on already in the questions with cardiac injury, but also the intersection between cardiovascular medicine and the care of these patients, in particular an area of my expertise, the QT prolongation and drug safety, as we've attempted to treat many of these patients with chloroquines. Then, but also the treatment of the cardiac disease. And as Barbara so elegantly teed this up, you know, we have patients that are avoiding treatment, and not just STEMI, but now more chronic management. How do we start to reopen our centers to the care of valvular heart disease, for example, and when do we do this and how? And the final part is going to be intermingled into this argument. I think that we have a responsibility that even in times of crisis to generate the best science. Well, here is where I need my pointer a little bit. This is a very recent heat map of transmission. This is the R0 function that we're so now becoming familiar with transmission in the United States just about 10 days ago. Where I live is in the very center. So hopefully you can see my pointer. I'm in Indiana at what is called the crossroads of America. We all know the painful process that our cities like New York and New Orleans went through with the COVID surge. But I live here in the center, and this is my state. So you can see that how you handle COVID depends very much on where you are. That there are hot spots in my state that in the span of 10 days have markedly changed. And so where you are relative to this pandemic is very, very important for how you manage. And our School of Public Health just 2 days ago published online a random sample. So this is a random sample across my state of COVID testing showing that fully 1.7% of our population is COVID positive by random sample, and 1.1% is antibody positive, giving an estimate in my state of 6 million, an estimate of 186,000 patients infected, which is 10 times greater than the reported number of positives by the testing that's been provided in my state thus far clinically. So there is a heterogeneous spread, and we're beginning to see some objective data about just how many positive cases we have, and we presume that a lot of these patients, or a lot of these people rather, are asymptomatic. What that has resulted to is this bar graph of my own hospital. We are the largest hospital in the state of Indiana, about 800 beds at any given time. And here in the center, where this is about April 1st, and you can see that we ramped up a little bit later than Europe. But now we are in a phase where we have a virtually constant in and out, about 80 to 100 patients at any given time, about 10% of our beds occupied by COVID, about 30 patients on ventilators, and about 10 on ECMO. And this is flat. This is as of Friday. So this is not relenting. So we are seeing not only a surge, but a sustained impact on our healthcare systems that we need to deal with. And Barbara showed much fresher data than this, but I echo, and our own experience is about 30% decrease in our STEMIs. This was published in the Journal of the American College of Cardiology in April, but really Barbara's data is much, much, much more up to date. So in the US and led by academic centers, I think we're pivoting, we're changing our focus from the surge that you saw and the chaos in New York and New Orleans to now a steady state of this virus being present in our communities. This is requiring us to manage a very new type of reality for how we have to deal with not only COVID, but with cardiac disease in the era of COVID. And not only treating our patients, but keeping our staff healthy. Our critical clinicians must be kept healthy in order to care for the patients that we serve. So our academic centers, I think, these are my personal thoughts. We need to help clinicians understand and treat the COVID consequences. And injury was mentioned. And I think that Barbara mentioned that this should be no surprise. And here's data to say that this is no surprise. This is not COVID. This is ARDS and biomarker positivity and mortality. This is 2012 data, just taken from ARDS patients in general. And you can see in the survival probability, those with higher biomarker positivity and troponins have a much different survival curve and a virtually linear impact on mortality based on the quartile of their troponin positivity. So these patients suffer injury and they suffer the consequences. And this is borne out in COVID, both from the initial and subsequent reports. This is a very frequent occurrence in COVID patients that they have myocardial injury. But how do we treat this and how does this manifest is very, very protean. We see these pseudo ST segment elevation myocardial infarctions, but we've also seen incidences of stress cardiomyopathy, acute heart failure, and a particular point of emphasis in the United States has been this whole notion about thrombosis and injury, both cardiac and non-cardiac injury, secondary to thrombotic complications. And here's a paper, again, rapidly produced about the high risk of thrombosis in these patients, and I think this has been confirmed over and over again. In order to guide our clinicians, though, in how to approach this, we need much better and detailed science on what are the potential mechanisms. And these are just some of the potential mechanisms for damage that can be produced by COVID. Whether it's inflammatory or direct, microvascular or macrovascular. And don't forget that our therapies, hydroxychloroquine can rarely produce a cardiomyopathy. So we also have to realize that our therapies that we are proposing during this crisis need to be not only effective, but safe. And that gets me into this coalescence of the generation of good science and the balance of risk and benefit for proposed therapies. And I'm going to use hydroxychloroquine as an example. And just in terms of my own particular area of expertise, I have spent the better part of the last 20 years looking at drug safety and especially QT prolongation. And I want to stress one point with you all, that even in a pandemic and even in a time of crisis, our science needs to be uncompromised. As an example, 3 rapid publications have been produced related to the QT interval prolongation and its consequences in COVID patients treated with hydroxychloroquine and or erythromycin. This one in April 24th in Nature Medicine. This one 5 days later in Circulation. And this one May 1st in the Journal of the American Medical Association. All single center, retrospective, rapidly produced studies to study this issue of QT prolongation and the risk of a therapy that we are widely prescribing in the United States. There were a lot of similarities between these studies. Well, they were all quite small, they were retrospective, they were single center, and they were not rigorously adjudicated. But 11% of patients had markedly prolonged QTs. The first study quoted no cases of torsade and no mention of discontinuation of therapy based on the ECG data. The second, 10% with marked prolongation, no torsades, but 7 patients who had therapy discontinued. And the final study, 20% prolongation of QTC to extreme levels, 1 case of torsade, and 10 discontinuation of therapies. So there's similarities here, but what was concerning to me were the differences in the conclusions of the studies. And I want to go through these rather carefully because these words are quite important. One study proposed that the QTC should be followed repeatedly, should, not must, but should, but particularly those in comorbidities and using other QT prolonging drugs. A second study said clinicians seldom needed to discontinue therapy, and further study of the need for QT monitoring itself is needed. And the final, that clinicians should weigh risks and benefits and closely monitor the QT. So anywhere from we don't need to look at this, that this is not a concern, to it should be carefully monitored. Well, I would submit to you that science has already spoken on this. The clinical evaluation for the potential for this particular toxicity has been internationally harmonized for the last 20 years. It has been updated within the last decade, and the science and the methodology to assess the risk of a QT prolonging drug is the same anywhere in the world. None of these studies follow this. Second, in the United States, our own societies, the American College of Cardiology and the American Heart Association, have both issued scientific statements on the prevention of this complication in hospital settings. This was ignored by the authors of these studies. And finally, my own group has developed and validated a risk score for who will have the most QT prolongation in the hospital. These were prospective, randomized studies. These were expert consensus opinion based on data gotten not during a pandemic. But what I would submit to you are significant contributions to the scientific literature that should not be ignored because we're dealing with a pandemic. So in my opinion, there are some problems, and this can be evidence for as we go forward with other issues, whether they are issues related to the effectiveness or the safeties of therapies. But we cannot apologize for poor study design and methodology. The haste to publish has to be considered. The world is hungry for this information, but we also cannot apologize for poor editorial oversight and poor scholarship. I'm quite opinionated about this. We need to deal with this. This will be handled with time, but nonetheless, as Professor Zanned opened this, talking about there's been a great deal of information and disinformation in this area. We have a lot to do as academic leaders, scientists, and clinical leaders in the world in order to make sure that we react to this pandemic appropriately. So I would like now to turn this over to my colleague, Dr. Valentin, because Dr. Valentin is really expert in how we communicate within our societies, across societies around the world, in communication of the best information through things like this webinar. are very, very important. But Mike, I'd like your thoughts on how we go forward with and what avenues for good communication that we have.
Thank you, Dick. Can you hear me appropriately, Professor?
Perfect. Okay. Yeah, and I'll change the slides when you need me to change.
Okay. I think that, first of all, I would like to thank each of you for participating and for Professor Abid for hosting this and Professor Zanned. This has been fantastic and really the type of open exchange of which we have all been looking forward to. And I think that this is just excellent in the way that you have performed this. I'd also like to congratulate each of you for opening up your websites and for ESC and for ACC to be able to share this type of information. As we know, we have thousands and thousands of members and millions of patients who will benefit from this. Dick Kovacs was the leader of our taking ACC 20 virtually. And Dick, you'll have to let me know at the last time we had over 50,000 participants in ACC 20 virtually. And I know that Professor Casadei, I know that you are looking also at this for ESC and how do we do this in the best way possible to share information. Above, you will see in front of you is some of the way that we have been sharing information at ACC. Dick, I'm not seeing the shared screen anymore. Let's see if we can pull that back up to the COVID hub. Dick, if we can pull that up on screen sharing.
I'm trying. It wasn't me. It was. Is that?
Well, I'll keep talking as we're trying.
I'll keep trying.
So, and Barbara, I know that ESC has done a brilliant job of creating a COVID hub for members and for others to be able to access. In ACC, we created a COVID-19 hub. This COVID hub has become the epicenter of information sharing and of the latest data and the latest ability to share best practice in management. By using the COVID-19 hub and our board, here's the COVID-19 hub on ACC. By using this, we have been able to assimilate shared data across the country and across the world of people bringing together best practice in management. Best practice sharing on a rapid basis, we believe, has saved thousands of lives, has saved healthcare workers, and has enabled us to be able to show and share the ways that clinicians are getting on top of this and getting ahead. While our governments battle between opening, closing, and what is right and what is wrong to do this, our science has been shared brilliantly. And I think in my institution alone, we have benefited from all of the different parameters. We were able to quickly adapt our cath labs, our EP labs, to the most recent data available in how we should prepare. For PPE for our staffs, we were able to share. We conducted webinars with our Chinese partners in Wuhan, who showed us all of the things that they had learned in management 30 and 60 days after their crisis, and what had been effective in managing not only for their patients, but their staffs and their clinicians. Being able to share 2 webinars like that in a very short period of time guided the most critical hospitals in New York, Chicago, and in New Orleans, and in Washington State to be able to prepare much quicker. And Barbara, you showed the numbers that you're seeing in Europe and across Asia. In my hospital, we have seen a 45% decline in STEMI, but we've also seen a 50% decline, 50 to 60% decline in heart failure admissions. And so with this, we had to react very quickly. We shared this data on the ACC website. Data came back to us very quickly from across the country that we were seeing the same types of STEMI and of heart failure admissions and readmissions declining rapidly. We then were able to mobilize our heart failure team to start contacting the highest risk patients at a much faster rate and to determine, are these patients dying at home or are they under better care because they have family members at home now to help them with their medications, and they're not eating out, they're eating in, they're watching their diets more closely, and perhaps those family members are making much better control of heart failure than we had seen before. Those types of efforts have really helped us dramatically. We have been able to also share best practices in telehealth. And I don't know, Barbara and Professor Zanned and Professor Halima, when you're trying to share telehealth secrets, one system is only as good as one system. In the United States, we have multiple different systems and difficulty in, again, creating a best practice for telehealth for our professionals and our patients. Sharing this information on the COVID Hub and on the Board of Governors listserv, in which we rapidly disseminate best practices across all of our states and internationally to our international partners, has really helped us dramatically. My practice, like Dr. Kovacs and many others, learned in 2 days the 3 different best practices for telehealth, the systems of utilizing electronic health records and how to access patients, not only on Android systems, but also on Mac systems, how to get access to elderly patients who did not have the same technological experience. So in all, we have seen that perhaps the art of communication in COVID-19 is as important as the science. And our ability to disseminate good and safe information as quickly as possible has really shown the good side of our organizations working together. And so I'll stop here because I think that there is so much for our members and listeners to share and to ask. But I would just say thank you to Dr. Kovacs, Dr. Casadei, Dr. Zanned, Dr. Halima, each of you, and Professor Abid, each of you for opening up the communication websites to be able to share this information with those who so desperately need it on the front lines.
That were
Thank you.
2 great presentations. So maybe I would, on behalf of my colleagues from the Tunisian Society of Cardiology, thank all of you, and I'd like to open the floor for questions. And I like very much the various overviews on the cardiovascular risk and cardiovascular diseases in COVID, and including the safety issues related to potential and not evidence-based therapies for COVID. And then the discussion, which really is very important, on evidence generation and what kind of science should we be relying on. And finally, the way that ACC, certainly ESC and professional society have been tackling the dissemination of knowledge, which in my opinion is best indeed when it is filtered or graded by professional society, which is much more responsible than the social media or the lay media. And by the way, potentially more responsible than the major journal editors, because I understand, I have heard, and I can't agree more, that there have been a lack of editorial oversight with this haste in publication, even in major journals. So I'd like to open up the floor for discussion, and I can see some questions coming in here, and I try to translate if they are asked in French, not a problem. Please, anyone wishing to ask a question, please.
Professor Zanned, I just report our Tunisian experience.
Sure.
Our hospital, I work in a hospital which was designated as a COVID hospital. And since the announcement of the lockdown in Tunisia, the confinement was announced very early. And we noticed really a low number of patients who were hospitalized. Roughly, they didn't reach even 50 patients in our hospital. And I agree with Professor Valentin. We learned a lot of sharing experience with webinars with mainly our European colleagues who attracted our attention to cardiac complications such as the thromboembolic events. And effectively, we paid more attention to these complications and we treated them very early. Then just one remark that we didn't have really a lot of patients and a lot of cardiac complications in our cardiac department, which was designated as a COVID department. We didn't have, since 20th of March, any hospitalization for cardiac diseases. We had only two cardiac complications, one myocarditis and one acute coronary syndrome. They were COVID patients, and they were treated by our colleagues in the intensive care unit. Then I think that we really were lucky. We were lucky to have that the epidemic began later than other countries. And in our hospital also, we had daily Zoom meetings. We formed a COVID team, which consisted of pulmonologists, cardiologists, anesthesiologists, pharmacy, and we discussed daily of our problems. We discussed of cases of patients that we discussed their EKGs, and this telemedicine allowed us to share a lot of experience. This is roughly our experience in our hospital.
Thank you so much. I can see a couple of questions coming here, and certainly one question is whether it was wise to lock down most of the healthcare system and in order to get it ready for COVID, and whether this hasn't really deprived some of the patients to access to normal healthcare, whether you have such experience in UK, in Europe, or in the United States.
Well, it is interesting. In the U.S., we attempted to try to preserve some hospitals in our own system. We were able to preserve our hospital that is dedicated largely to cancer care and solid organ transplant, visceral transplant, not cardiac transplant, but livers and kidneys, and try to keep that hospital relatively free of COVID. We had one case that appeared there, but otherwise we kept that COVID. We tried not to lock down the entire system, but because of the US's lack of testing, of effective testing, essentially the rest of our hospitals were flooded with patients, before an organized approach could be made. So most hospitals became COVID hospitals. Only a few hospitals could be kept relatively clean. Mostly those were hospitals without active emergency departments.
I'm sure we'll learn much when the crisis is going to be gone. hopefully sooner than later, we will learn much. And one of the lessons which may have an enduring effect is the telehealth. And I have one question here from Dr. Anisa Lumi on whether the telehealth experience would enhance the use of telehealth outside the COVID crisis later in usual care. Any thoughts about that?
May, almost certainly. I think that our experience of telehealth has been really revolutionary. There will be no reason to have patients coming in for certain aspects, simple follow-up, etc., can be very remotely exposing patients, particularly sick patients, also to waiting rooms, particularly in the winter, particularly when other viruses are ongoing. So I think that we've learned a lot, and some of this, has been like a fast food in some respect. We have forced it, and now we know how to do it, and we know that it works.
I can hear some back noise. Anybody not speaking, please mute yourself and just unmute yourself when you have a question. Thank you so much. I can see a number of questions coming on treatment and medication. I will try to summarize them. But before we get there, I have a question on how the healthcare system has been organized in some places and whether managing a place with non-COVID in hospitals, so therefore the common care can be perpetuated, has been implemented in some places, and what would be your advice? Maybe we'll start from the American experience and we'll get to Barbara. How did you manage in many places in the United States?
I can speak, and then Mike. We suspended virtually all elective routine cardiac care, so our echo labs, stress labs, cath labs, other than emergency patients in the hospital were all of those procedures were canceled or postponed. All visitation in the hospital, there was no visitation in our hospitals, and that lockdown. As of the last 2 weeks, we have begun slowly, with the highest priority cases, begun to bring those patients back at about a roughly 25% of our capacity in order to allow for no one to wait in a waiting room, for appropriate social distancing, for questioning, for screening, and all of our patients who come to the cath lab for any reason now, for example, are COVID tested within 48 hours prior to their arrival in the laboratory. Mike?
Yeah, our experience has been very similar. We have a lower, because I'm in a more rural area than Professor Kovacs and perhaps many of you, we prepared for a surge that has not been as severe as we had predicted so far. We have flattened the curve relatively well here in Central Virginia. That has allowed us, we had a master plan, Professor Zanned, to redistribute resources as needed. So far, we have been able to hold some resources where they were and to be able to redistribute only as needed. So this master plan of redistribution of nursing, PPE, etc., had different phases depending on our surge levels. Our surge levels have been lower, and we have been fortunate with that. So, so we've been able to hold off. Like Professor Kovacs, we restarted elective high priority cases about 10 days ago. So we're in our second week of doing structural high risk AS, all these cases that have started back. Again, like Professor Kovacs, we're at about 30% of where we would have expected to have been otherwise, but we're in phase 1 of return, and we'll see how this goes in return to phase 2.
is it better to have a regular normal activity in consultation and in cath lab?
The data I showed from our situation is that we have a constant influx of cases. We handle our cath labs assuming that the COVID virus is in our environment. Our random sample of our state shows that the infection is probably 10 times higher than was estimated by initial testing. So we are assuming that this virus is with us and will be with us for a long time, and we will manage our cath labs accordingly by testing everyone who enters our cath lab for an elective procedure for the foreseeable future. So it is not normal for us, but we are far different than Tunisia. But I don't foresee when we will ever be normal. I think we are changed for a long, long time.
Yes, these healthcare system organizations are different from one country to another, not only because the epidemic is different, but also the healthcare organizations are different. So each country has to learn from experience from others and adapt to their own local situation, I am sure. But certainly they have been experienced into having different tracks, COVID tracks and non-COVID tracks in hospitals in order to keep offering healthcare to non-COVID patients. So each country needs to adapt. Now, there have been quite a number of questions on testing and even fewer more on therapy. Well, testing, one question is about CT and PCR, and the other about testing for COVID. And I know this is also very much dependent on the healthcare system and the availability of COVID testing. So what is the current situation now in Europe and United States, whether testing for COVID is universal or only in patients with symptoms or only with severe patients? What is the tendency?
Maybe I start
Yes.
Europe is incredibly variable and has been really dependent on the ability of that country to mass test. So Germany has tested enormously, and as a result, the same way that South Korea and New Zealand has had a much better being able to contain the infection. And this is also part of the answer of the question before. I mean, if you have a test and track system in place in your country, in your hospital, you can give yourself more room to maneuver in terms of how many procedures, how many patients you can actually look after than if you do not have a system like that in place. So in some countries, the testing is there. In some other country is there, but not at the level that it should be. The tracking is missing in particular. And when I say tracking, is to have those apps that allow you to track through your phone whether you have been in contact with someone who has tested positive, and therefore you self-isolate and reduce the probability of infecting other people. So these are the basic public health measures that one must take in the presence of an infection, and they are only really carried out by a minority of states. The other thing that is coming up is serology now. So to actually see how many patients have antibodies against, so as have had the infection and have developed the antibodies, and therefore they can donate their immunoglobulin for the treatment of other acute patients. There are some trials ongoing on that, and actually see whether that immunity is completely protecting and for how long it will be protecting. So these data will be essential once out in helping us managing the pandemic and the patients that come to hospital.
Then I'll ask you some questions. Dr. Abdeslam asked the following question: How can you explain the discrepancy in terms of incidence and mortality rate between North and South countries? could answer, please? Did you hear me?
Yes, yes.
Well, certainly, Barbara, you can answer that when it comes to the bridge between Europe and Africa, and maybe our American colleagues can let us know about the North and South America, maybe.
Yeah, I don't think it's the climate, if that is part of the question. I think that is, as I alluded during my presentation, it's the mean age of the population that is affected. So, you know, the countries like Italy, the United Kingdom, France, have a vast proportion of the country population that is over 65 years old. And that is where the virus has really killed the, the vast, the higher number of people. I was discussing the same question with some colleagues from Sub-Saharan Africa, and where they have a minor, the proportion of patients above 65 is much, much lower, and the rate of mortality is much, much lower. So there are many other things, like comorbidity that also come with age. Possibly, to some extent, morbid obesity is a risk factor. But one of the key is age.
And another question: is there any significant?
If you don't mind, let's hear from the United States first. What is their take on the North-South difference? If you don't mind, please.
I agree with Barbara. I don't think it is a climate difference. We've all seen data that there are hot spots within South America with tremendous transmission and mortality, but it hasn't spread to the extent. In the United States, again, some of our cultural things that we have in the United States, our hotspots have been nursing homes, where our elderly patients are congregated in close proximity, our prison systems, and some of our industries, particularly meat processing plants, which have really been hotspots. So I think some of it is how we do things culturally, but I don't think it's a temperature difference.
Another difference is about the healthcare professionals versus all population. What is your experience in your country where the healthcare professionals have been hit harder than the remaining population, and what kind of protection are you advising for healthcare professionals? Let's get it in order. Again, Europe first and then the United States. Barbara?
Yes, I mean, being care workers have been the one at the highest risk.
Yeah.
They have the exposure and they have less availability or access to proper PPE. So we haven't had an increased rate of infection in people in the cath lab, for instance. But certainly care worker, taxi driver, bus drivers, and amongst the doctors, the first that were hit very badly were the ENT specialists and the dentists and the ophthalmologists, because they do come so close to patients during their consultation, and they, are working in mouth and nose, where the virus congregates. So, those are where the highest, there were the highest number of fatalities in there. As I said, it's care workers rather than, basic cardiologists or anybody who actually is in the hospital with PPE available.
Another question, please. Do you think that elevation of cardiac troponin includes only a simple marker of severe form, or the myocardial injury is a direct cause of death in these patients? The elevation of troponin. How do you explain this? Is it a severe form or direct, or is it related to a direct myocardial injury?
We're starting from the States this time?
We can. I did want to give the United States perspective on that last question about healthcare workers and introduce one other concept that we're beginning to see. I agree with Barbara. Our cardiology teams have not been specifically affected in a disproportionate fashion, but there will be some data coming out on the experience of the healthcare workers. And one of the drivers in the United States was that many relatively inexperienced healthcare providers, residents, were put in the front lines of evaluating and intubating patients with COVID. The experienced healthcare workers and experienced anesthesiologists and critical care specialists could do this safely, but the inexperienced workers expose themselves at a higher rate. So we'll start this. So experience matters. So in terms of the United States experience with injury, I think the data on whether this is direct toxicity or just a biomarker of being sick is still controversial. We have seen very few cases where we feel that this is a true COVID myocarditis. But we see many cases in which there are troponin elevations, and yes, as with ARDS, the magnitude of the troponin elevation is almost linearly related to the mortality. But I think it's just a biomarker. My personal opinion is that this is a biomarker of the severity of the illness and not necessarily a biomarker of underlying direct cardiac toxicity.
May I share with you unpublished data we are soon to publish with Mike Valentin from Houston on the ARIC cohort, where we have collaborated in measuring with omics biomarkers, a whole range of biomarkers in the ARIC, and this is outside COVID, just to find that ACE2 and troponin were very much correlated, and both of them were high risk factors for cardiovascular diseases. So whether there is any hint here that troponin is also, paving the way for higher risk of COVID because its association to the level of ACE2 is pure speculation. I just is adding 5 cents. I'm not sure that it helps much at this time, but these are among the various lessons that the future will tell us.
Another question dealing with the biomarkers. It's a question asked by Professor Ardira, who is a pulmonologist. Do you think that in COVID-19, a certain cutoff point of D-dimer should indicate further investigation for pulmonary embolism, regardless of other signs?
This is about thrombosis and D-dimer. There are a number of questions about thrombotic diseases, anticoagulants, and this specific question is about whether D-dimer may be useful in assessing the risk of pulmonary embolism, of vital thromboembolism in COVID patients. What is your use of screening for risk of coagulopathies? America first.
U.S.
Let's get the U.S. first.
Okay, U.S. first. I'm going to first make a disclaimer that these kind of thrombosis biomarker, this is not a particular area of my personal expertise, so I'm just going to give a general impression. But our index of suspicion for thrombosis is very high. We don't have a particular strategy that I'm aware of in my own institution or a consensus around the country of cutoff values for things like D-dimer. But I can tell you that prophylactic antithrombotic therapy is used universally, and there's a high index of suspicion for thrombotic complications, both venous and arterial thrombotic complications of the disease.
I would say same here. There is a lot of a lot of people are reporting. People, for instance, in Belgium, there is a unit where they do Doppler in every patient with COVID, and they see a lot of thrombosis. Almost in 70% of these patients, they can see deep vein thrombosis. They can see all sorts of thrombotic, including strokes. And people are really wondering whether one should randomize these patients for anticoagulation, but equally these patients, when they have this in intensive care, these thrombi are very sick, their hemorrhagic risk is very high, and the general idea is that one should tackle the inflammation, that the thrombotic events are a consequence of the endothelial damage secondary to the high inflammatory states, and that's why there are now studies that are randomizing antibodies against the interleukin-6 receptors, that have been shown to be beneficial in a Ebola disease that is also associated with a strong inflammatory response.
Thank you. This is a perfect transition to the many questions about therapy. And we have a number of questions about chloroquine, about zinc, about remdesivir, and the state of knowledge so far, because there have been a number of papers, and many of them are with contradicting results, not consistent. So what is the state of knowledge right now, and whether we just know that we don't know, and we will keep waiting until these large trials would deliver? Maybe a quick summary from Europe first, and then we'll have an answer from the United States. Barbara?
I think we know nothing. So I think that whatever it has been published so far is contradictory simply because, as you said at the beginning, we have seen incredibly poor papers published in very reputable journals, open label, sort of randomized, small numbers, undue emphasis on secondary outcomes, all of the kind of things that we know jolly well will get us into trouble, right? And the danger that I feel is that good data will come up, because there are several studies, some of them large, that are will be yielding results that are more definitive, and including other observational studies or mechanistic studies, and that will struggle to be published because people would have ticked the box and said, "Oh, we know about that. We don't need to randomize that. Because we know that this works, because in that small study, in a secondary outcome, it showed that there was some effect." And that worries me enormously because, I think, like Professor Kovacs said, the virus is here to stay, and we need evidence, good quality evidence. And all of this starting treatment because in the hope that it's going to do something without proper evidence is actually going against the collection of the evidence that we need to treat these patients.
Thank you. Dr. Kovacs, Dr. Valentin?
Well, I agree entirely with Barbara's statement that we don't know. The chloroquine data is unconvincing. Remdesivir in the United States was approved on an emergency basis when the Data Safety Monitoring Board prematurely stopped the trial before we had the mortality data because they saw the signal of fewer days on ventilator. And I have great cause for concern about when we are stopping trials for those kinds of endpoints and giving emergency approval to drugs. we have to continue to stand up for the best science.
And agree with that, Dick. And Dick is an expert on this area. One thing that's been very interesting, Dick, is that remdesivir now is unavailable to many of our institutions that are hotspots and have some of the most critically ill patients. And some chief medical officers that I'm close with are unable to get the drug now. So how do we include it in proper testing when we can't use the medication in hotspots where we have the sickest patients?
Yeah, we're really setting ourselves up to have a real problem, even with observational studies post availability of the medication. I see little reason to abandon scientific principles because of the great chance for unintended consequences for some of these therapies.
Well, I can't agree more. And actually, we will also have to draw lessons from the current crisis, which is also the crisis of evidence generation. And my advice is that the facility to collect large volume data, they call it big data, and to curate them has caused much haste into interpreting this observational data. And this has been faster to deliver than appropriate randomized clinical trials. And we know how much these observational data are fraught with confusion. No matter how much you can adjust for any compounding factor, they all end up not being established in causality. And Barbara, I know you and me are, for good reason, on the same side of randomized clinical trials, but still there is concern even within the randomized trial enterprise of failure. In Europe, we haven't succeeded in doing pan-European studies. In France, has been leading a European trial. They have been able to enroll 700 patients in France, one single patient outside of France. This was in Luxembourg. And this is just because the subsidiarity, they call it, each country will govern their own authorities, and there is no concerted effort in order to approve trials at once in many places in Europe. And the experience from the DSMB in the United States, we had exactly the same experience in France, where a remdesivir trial was stopped for the same reason by the sponsor against the will of the DSMB, just because they have seen this signal. So this is another matter of concern. Even the randomized clinical trials enterprise, there are lots of issues to fix, and maybe the main lacking, the major gap is educating people on rating the evidence and relying more on randomized clinical trial than observational, but even in randomized clinical trials, relying on good methodology. Barbara, I'm sure you have your own take on this.
Absolutely. I mean, the sponsor should not interfere with it in that way, and we know what that has done on the value of the shares of the particular company. So these are considerations that have nothing to do with science. But it is true what you said about Europe. But if you take into consideration the fact that COVID infection must be the same, everywhere. The recovery trial has recruited 10,000 patients in the UK. And so there is a hope and is continuing to recruiting at a fairly high rate, even though the rate of infection at the moment is a streamlined clinical trials, is been endorsed by the government and by the national health system, and that has really helped pushing it through at a great speed. So I think we have hope that from trials like that, we would at least, even knowing what doesn't work with certainty would help safety, as Rick was saying, and would also, help us with resources, to direct them versus what works without wasting any time and exposing patients to undue risk with drugs that don't, and that we just give just because we feel like we need to do something.
I checked yesterday the clinicaltrial.gov, and there have been 1,500 studies in COVID-19. 1,500. I don't think that we need that many, and this is just one sign of the disorganization of the scientific community and worldwide, and WHO not leading coordination. So what makes people get to the 1,500 studies? It really doesn't make sense. So one question to our colleagues in the United States, but certainly also for you, Barbara, is when earliest do you believe that we will have some clues, hard evidence of benefit or lack of benefit from the currently competing medications? When earliest?
Well, you know, as they say, you know, you can predict everything except the future. But, you know, I think that, you know, if you look at the trial that I know best, which is the recovery trial, that is a trial that has been, because it is impossible to have accurate power calculation, you know, it will run until it can see a message. You know, it is an adaptive trial. So you know, if there is a new treatment that come in that looks promising, it can be added, and those who do not look promising will shed off in time. So I would expect a trial like that to produce some result one way or another in a matter of months.
Any clues from the United States on when are we promised to know best?
Well, I'm watching in terms of the chloroquine issue. There is a better organized, randomized, blinded trial of healthcare workers going to be administered. This is being done under what is in the United States called PCORI, the Patient-Centered Outcomes Research Institute, that is going to test the hypothesis that this, given earlier or even to asymptomatic frontline healthcare workers, may help prevent acquisition or severity of the disease. But that's going to be a 6-month trial. And I don't know where they stand in terms of enrollment. They had to modify their safety monitoring based on what we've seen now with QT prolongation. They weren't going to do any safety monitoring, but they are now. So at least 6 months in the US before we see any further randomized data on chloroquines.
Thank you. I understand we still have 5-6 minutes to go, and there are 2 questions which I can convey and I could read. One is on mass screening, whether this is a policy that should be adopted in countries like Tunisia, and the other is about the Kawasaki disease, whether you have seen cases such as this, and what are the front signs that we should worry about. So let's go for mass screening first, and have the United States answer first the question about mass screening.
Mass screening in the United States will require a major change in public policy. It will require major discussions about privacy and personal freedoms, and an increase in technology. I don't see the United States going to mass screening in that regard in any time soon.
One of the problems that we've had in the United States, and perhaps you're seeing it in Europe as well, is that each state in the United States carries its own governance models and rules, which has interfered with, as Professor Kovacs said, with national public policy. And so we have a wide range of state policies that are interfering with this. And so the ability to test in each state is very variable as well. And so right now, not only are we struggling with policy, we're struggling with the ability to get proper testing, and we're struggling with the accuracy of testing. And many different labs have developed their own tests. And so, Dick, I would love for you to talk about, and Barbara, about different testing. I mean, we're struggling with the accuracy of tests and the availability. And so getting proper public policy for mass screening is almost impossible in the United States. And I can imagine in Europe, you're looking at the same issues.
Yeah. The issue of accuracy, at least in the UK, has been resolved by centralizing the testing. So, by actually having a major center or 2 or 3 major centers in the various states of the United Kingdom, Wales, Scotland, England, that deal with the tests, so that you can have a proper checking of the methodology, and so the centralization has worked in that respect. In Germany, for instance, that, as I said, has been the most successful country, they didn't need to centralize it because they already had so many high quality labs that could do the testing, even within pharmaceutical and other biotech companies. They were already performing at a very high level. I wouldn't leave it to the hospitals necessarily, to the mass test. The problem, the main problem, is how to deliver it. I mean, the UK, for instance, have been promising 100,000 tests a day since the beginning of March, and still hasn't reached that target. So it's actually to get the blood, getting into a center, and then performing the test. Each of these steps is fraught with difficulties. So it's not an easy thing to do. Smaller countries have been more successful in doing it, but if you do it, and you do it repeatedly, there is no doubt that works. It works in containing the infection, particularly, as I said before, if you couple it with the ability to track the patient that tests positive.
So to end this talk, and this discussion, great discussion, 2 very short, specific questions. So this may be addressed by short answers, and then I will try in less than a minute sum up what we have heard so far. One is about ECMO, whether the US and UK experience with ECMO, whether it has been helpful, what is the mortality related to ECMO, and what are the eligibility criteria in your countries about ECMO. And the other, it's even more specific about Kawasaki. What should be done in order to avoid these young kids being, deceased with Kawasaki? So let's get COVID and ECMO first. Dr. Kovacs first.
ECMO is used. The criteria, it tends to be used in the younger patients, but as you can imagine, our mortality, I don't have the exact mortality figures in our own institutions, but it is very high. So the utility of ECMO in actually ECMO to survival is our experience is not good in our own institution, and I think across the United States. The other unintended consequence of that is the unavailability of ECMO and the perfusionists to run the ECMO to be able to treat our advanced heart failure patients. So far our experience is not favorable on ECMO.
Barbara?
Yeah, I don't have much to add to that, except that a lot of people who are non-expert in ECMO have been put in charge of patients with on ECMO patients because of the situation, and it is difficult to know whether the mortality. We don't have really anything we can compare mortality with, because by the time a patient with COVID is put on ECMO, the situation is so desperate. And so, again, it will be one of those things that are not going to be terribly scientific, I'm afraid.
Yeah. So I'm afraid we are running out of time. So Kawasaki is very uncommon right now, and we'll have to gather more information in order to know best about this disease hitting young kids. And I can see another question coming here on the risk of reinfection. This we will really not know until we wait. And a common conclusion to anything we have heard today is that every country is doing their best in order to organize the healthcare system. We understand that organizing separate tracks of COVID and non-COVID can be very helpful in order to offer care for our cardiovascular patients in non-COVID places and safe places. I also understand that screening can be very helpful if you can afford it and if you can get organized, because it is really challenging and it depends also on your own healthcare system. There are many aspects of the disease that we are still uncovering. This is the case of coagulopathy, and we mentioned Kawasaki and many other risk factors. But when it comes to treatment, the main message is that we know that we don't know when we best wait until the randomized clinical trial really deliver. And it is very important that we rely on information which are filtered by the professional societies and keep ourselves away from fake news, from Facebook and from the social media, and rely on professional societies such as we have seen on the ESSC portal and the ACC portal. And maybe the final word is that if at all possible, we need to keep enrolling patients in randomized clinical trials. And I know that in Tunisia, they have quite a significant clinical trial program just starting, except that there aren't so many patients for the time being in Tunisia in order to be enrolled in these trials. But this is the best way to address this crisis situation, generate good science and apply good science. So maybe I stop here and I will hand out to Dr. Ben Halima and Dr. Abid to lock this conference. Thank you so much for your great discussion and great input. It was a great privilege and pleasure for me to moderate this session.
Thank you, Professor Zanned. Just two last questions concerning vitamin D and vitamin D. What do you think? And the nicotine and COVID. What's your point of view concerning these two questions?
Well, the generic answer is that we don't know, but maybe Barbara knows or Dr. Kovacs knows.
No, vitamin D comes up every so often. Is the last vitamin left where we have a hope that it will do something. All the others in test ruled out. No, I don't think we know. You know, and nicotine, there are associations, and association do not imply causality.
Okay. And what do you think about telehealth and telemedicine for the future era after COVID? What would be the future? Would it be better codified?
I believe that we have unmasked something very important for us with telehealth. I think systems are learning telehealth very quickly now, and Professor Casadei mentioned earlier that this may revolutionize our outpatient therapy. And in ways in the United States, Professor Kovacs has shown that inpatient, we've also really enhanced telehealth inpatient as well. So we think that this may revolutionize care, especially for our elderly patients who have trouble traveling. If we can enhance this, then I think that this may be one of the true benefits of all this that we have seen not only in the United States but across the world.
Agree. We just a statistic. I looked at our visits last week, and our cardiology division did 75% of our usual visits, but we did them all telehealth. So we were caring for the 75% of the patients that we usually care for and doing it all virtually. And the patients are very satisfied, and we'll see how their health is over time. But it's revolutionized how we do things.
Thank you. Then Leila, it's for you.
If there is no question at the end of this webinar, I'd like to thank all the speakers, Professor Casadei, Professor Kovacs, Professor Valentin, for accepting our invitation and for sharing with us their interesting large experience, which definitely will help us in our daily practice. I'd like also to thank Professor Faiez Zanned for accepting to moderate this webinar, Professor Afef Ben Halima also for also moderating this webinar. And I'd like also to thank all the participants for attending this webinar and for the interesting questions. And I thank Americain Laboratory for his support. I hope that I see you in Tunisia, and see you later. Bye-bye.
Thank you.
Bye.
Bye.
Thank you.
Bye.